My name is Nick Wilcox from the University of Pennsylvania, and it's my pleasure to be speaking to Hyeon-Ju Ali and her clinical case recently published in JACC case reports. Welcome. Thank you for joining me.
Thank you, and thanks for this opportunity.
Perfect. Could you start by introducing yourself, like where you're from and what you've been working on?
Sure. I'm at MD Anderson Cancer Center currently. I am initially trained at Houston Methodist Hospital, which is just across the street in Houston as well. And my focus has been on pulmonary hypertension. So when I arrived at MD Anderson, I was surprised to find that cancer patients do have many different risk factors for pulmonary hypertension. That's not only related to cancer therapy, specifically dasatinib that we all know, but also more recently proteasome inhibitors like carfilzomib and alkylating agents can cause this rare form called pulmonary veno-occlusive disease. What I was also surprised to find is when I first arrived, I started seeing some very severe cases of pulmonary hypertension that were related to the cancer itself. So this is highlighting one of the cases. This is a gentleman, a 58-year-old gentleman with metastatic adenocarcinoma, really unknown primary, mets to prostate, rectum, liver, and came in to see me about a month after having his initial onset of shortness of breath. He was first diagnosed with pneumonitis. It was all in the setting of being on bispecific antibodies, and this is the first picture here where you can see the ground glass infiltrates. And after about a month of steroids, the infiltrates had resolved. But then by the time he came to see me, he said he went from essentially playing golf the weekend before to now having shortness of breath with some new findings on the chest CT that was really localized to the left upper lobe. So when I heard his case and the I think progression of his symptoms, we did the investigation for what I had seen previously as this case concerning for pulmonary tumor thrombotic microangiopathy. Initially, we started with an echocardiogram that demonstrated the RV enlargement and severe pulmonary hypertension. His RVSP was up to 70 to 75 millimeters mercury. At that point, we admitted him for rapid workup because we knew that this is a very rapidly progressive disease. The findings, for example, essentially within a day we got all of this workup done with the right heart cath showing again the severe pulmonary hypertension, his PA pressures mean of 39, his wedge pressure was 7, so obviously this pre-capillary pulmonary hypertension by right heart cath. And also based on prior cases we've had, we knew this was caused by essentially tumoral emboli to the pulmonary circulation. So we took a blood sample and looked in the cytopathology that showed some of these clusters of malignant epithelial cells. In addition, we also did an angiogram at that time, knowing that there were some infiltrates on the left upper lobe, and there was definitely decreased perfusion there. Finally, we also performed an FDG PET that showed that FDG avid uptake that was suggestive, again, of tumoral emboli. So putting this whole thing together, we diagnosed him with PTTM within about a day or so. Actually at admission, he was hypoxic, so we knew that based on the prior case reviews, I should say actually a systematic review by Dr. Godboll back in 2019 that he, average survival is about 9 days, so we had to move very quickly. So when he first came in, his creatinine had risen up to 1.4 from his baseline of 1 or so. He did have a mild lactate elevation, which is not shown here, of 2.3, and the NT-proBNP was also quite elevated in the 2000s. Once he had the diagnosis, we initiated him on sildenafil for his pulmonary hypertension treatment. And there were also some case reports largely out of actually Asia and Japan, suggesting that imatinib, because of its PDGF inhibiting properties, could play a role in reverse remodeling of the pulmonary vasculature and maybe improving pulmonary hypertension. And so you can see that the trend initially was that his labs looked better, creatinine and NT-proBNP improved, although he continued to be very severely hypoxic. And unfortunately, in the setting of, I think, a high vagal tone on day 12, he did have a PA arrest and PAD. past. And this was a unique case in that we were able to achieve antemortem diagnosis very rapidly, but also sort of confirm that by histopathology on autopsy. So here what we see, just to briefly show you, is essentially in the arrow are the tumoral emboli and the severe narrowing of the pulmonary vasculature because of the smooth muscle cell proliferation in the vascular walls. Essentially the takeaway here is I think, for patients with who have a known history of a metastatic cancer, solid cancer, and and comes with shortness of breath, pulmonary hypertension has to be on the top of the differential. And when PTTM is suspected, that we need to work quickly to achieve a diagnosis. And some of those antemortem, I think, findings that we can help to achieve diagnosis more quickly are the right heart cath using cytopathology to look for the malignant cells in the pulmonary circulation, and also FDG PET, even in the absence of that, I think is very helpful. So.
That was a beautiful synopsis of a very complex and sick patient. It's sorry about the outcome, but I think I'd urge everyone to read this report in full. I thought the thing that struck me about this case was the use of FDG PET and the pulmonary artery sampling on the right heart cath, before the patient decompensated, and then relatively rapid initiation of sildenafil and imatinib with improvement in the end organ perfusion, at least temporarily. That was impressive. And then, of course, a correlation with histopathology is all beautifully illustrated on your poster, but also in the case report itself. So I'd urge everyone to look that up. Thank you for sharing your knowledge and time with us today.
Of course, thank you.